Right. Okay, Bismillah, let's start.
Bismillahirrahmanirrahim.
Your first case, Dr. Mujahid, newborn male uh, with lethargy.
Okay.
You can scroll. Hello,
Yes.
can
Uh, this,
start.
this is the ultrasonography of the neonatal brain. Here I can see there is the posterior fossa structures appears normal, cerebellum appears normal. The lateral ventricles, there is hyperdensity is seen in the lateral ventricles. I think this is likely due to choroid plexus. Uh, I will look for this. No, this is not due to choroid plexus. There is a frontal horn of lateral ventricle is seen, and there is a hyperdensity is seen in the lateral cardothalamic groove uh, bilaterally. So this suggestive of hemorrhage in the cardothalamic groove bilaterally. This appears to be uh, uh, grade. I think this is a grade 2 because it is involving the less than 50% of the ventricle size. If it involves more than 50%, then we call it grade 3. So this appears to be grade 2, the germinal matrix hemorrhage, which is extending into the ventricle chain. So I will also do the CT scan of this patient. This patient also needs CT scan, and this findings should be, although there is no evidence of hydrocephalus, these findings should be conveyed to the neonatal team. So patient should be managed by the neonatal team.
Okay, this patient is 1 day. You will send this patient to CT scan for what?
Mm, there is a follow-up ultrasound should be done after 6 to 8 hours. If this hyperdensity is present, then the patient is deteriorating. The CT scan should be done.
What is the value of CT scan?
Just to see any extent of the hemorrhage, and to see any better evaluation of any parenchymal damage, any parenchymal infarct, any parenchymal insult, because the patient, if is deteriorating, to
Is
rule
the
out.
ultrasound not enough to evaluate these
Uh,
diseases in
yes,
neonatal period?
yes, ultrasound is sufficient, but
Okay, so what is the value of CT scan?
CT scan is to see exclude any
CT scan
ischemic.
of no value, Dr. Mujahid. Safety
Okay,
point.
okay.
Okay?
Okay.
Okay, how will you manage this case?
This patient, this finding should be discussed with this should be managed by the neonatology unit with intensive. I think this patient need conservative management, just to supportive therapy is advised.
Okay. What is the grades of
Uh,
germinal matrix
there is
hemorrhage?
if there is a bleed in the cardiothalamus groove, that is called grade 1. If it is extended into the ventricle but less than 50% area is involved, this is called grade 2. If more than 50% of the ventricle is involved, then it's called grade 3. If it involves the parenchymal hemorrhage or parenchymal infarction, along with the bleed in the cardiothalamus groove and the lateral ventricle also, with the parenchymal hemorrhage, this is called grade 4.
Okay. This patient with acute testicular pain.
Okay, this is the ultrasound of the testes. Here I can see console. Here I see the two testes.
You can
Uh,
scroll through the image.
yes, trying to scroll. No, it is not scrollable. Yes, no, it's scrollable. Mm, yes, right testes, and this is the. Mm, I think this is not written which is right or left. Anyhow, left testes. This is right. Uh, What is this testy? Right or left? This one.
Right test.
Okay, this is the right testy which is shows fellow. Now I'm going to see the left testy.
Your voice is so far.
Oh, no, 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 I will change everything. So there it says the left testes. Here I could not see the blood flow on the left testes. The right testis flow appears normal, and this is right testis.
Yes.
So the right testis appears heterogeneous, and there is also epididymis also appears to be heterogeneous, and there is the low density areas are also noted. Hypoechoic areas are also seen in the epididymis. This is just above. I will also see the color Doppler, but this appears to be epididymoarchitis on the right testis probably, because markers are not seen here. Um, I will correlate with the patient history of pain or any patient history of any trauma. Um, if the patient there is no history of trauma, so this likely
There is
represent.
history of trauma.
Okay, the patient have a history of trauma. Then these findings are made suggestive of testicular rupture, because the on the tunica albigena also appears to be uh, abnormal on the epidermis side. So they have finding likely represent traumatic induced. I will immediately inform this finding to the urology team. This patient also needs to be assessed by the urological team, and it should be managed further. And if it is not salvageable, then this patient needs archaeectomy. Uh,
Okay. This patient, 50 years old, male patient, worsening exertional dyspnea and chronic productive cough for several years.
okay, this is the. I think it is not scrollable. I should again send the request.
No, no, no.
Yes, yes, yes. Now it is available. Okay,
But please raise your voice.
this is the CT scan of the chest. Here I can see. Uh, I'm looking for the lung windows. Going scrolling the images from the top to the bottom. Going inferiorly, and this is the probably HRCT examination. Here I can see the multiple bully formations are seen in the upper lobes bilaterally, more marked on the left side. There is reticular shadowing is seen in the lungs bilaterally. There is loss of lung volume is noted on the right side. There is interstitial thickening is seen in the lungs bilaterally. There is also small bully formation is seen in the basal area bilaterally. So these findings are suggestive of bullous disease with background of ILD. I will confirm these findings to the referring physician. These findings should be discussed in the ILD MT, and these CT findings should also be
Which
compared
type
with.
of interstitial lung disease is this?
This is, I think, bullous lung disease, most likely due to some site of chronic hypersensitive pneumonitis, because there is ground glass shadowing, there is nodule and diseases involving the upper lobes bilaterally. So there is no honeycombing. So the finding likely if the patient history of acute on this history of acute onset, but this history is not acute onset, it's chronic history. So these finding likely represent chronic hypersensitive pneumonitis. I will also compare with the previous studies, and this case should be discussed in the ILD MDT.
Problem is okay. Can you check this images, please?
The same patient.
Yes, yes.
Okay, this is the CT scan of the abdomen and pelvis. The CT scan of the chest. Mediastinal
This is
video.
limited cuts. Go down again because the full stack of image is not working.
Okay. So this is the CT scan of the chest,
Any
non-complete.
other differential other than hypersensitivity pneumonitis?
Uh, mm, could be bullous lung disease. Could be some NSIP type. I'm looking for the esophagus. Esophagus is not dilated, and disease is predominant involving the upper lobes, so it could
Okay,
not be due to scleroderma. It
upper
involves,
loop fibrosis,
yes,
fibrotic changes. Okay,
could be due to
what could
ankylosing,
be the possible causes?
could be due to ankylosing spondylitis. I would like to see the bone windows. I would like to see the these coronal images to see the spine. This finding may be due to ankylosing spondylitis. Can I see the coronal images of this study?
Okay, this is the coronal spot
Yeah,
image.
there is syndesmophyte formation is noted bilaterally. So there is this finding is suggestive of ankylosing spondylitis with bilateral upper lobe fibrosis and bilateral bullous disease.
What will be your management?
This I will inform this finding to the referring physician. This patient should be managed by the rheumatology department. X-ray pelvis should be done to see the sacroiliitis, and this should be further compared with the previous studies. And these X-ray of the cervical spine should also be done to exclude any basilar invagination or any other atlantoaxial pathology.
Okay, I'll give you the history. This patient, 40 years old female patient with right hemiparesis.
Okay. Mm. This is non-sequential. Okay, this is the MRI MRI of the brain. T1 weighted images. 40-year-old female with history of
Right hemiparesis.
right hemiparesis. Okay, right hemiparesis. So obvious, could not see any pathology on this T1 weighted images. Now I am looking for the my review areas. There is no evidence of.
Please don't tell this phrase. Don't tell I couldn't see any obvious pathology.
Okay,
Okay?
okay,
Because the pathology will be present and you are telling the reverse that is no pathology. Okay?
yes, yes,
I'm looking at, and then you
yes,
can tell a negative.
yes. I'm looking at the foramen of the magnum. The now I'm looking for the temporal lobe. Uh, so there is ventricular dilatation is seen because I could see the temporal horn. So these findings are suggestive of hydrocephalus, mild communicating hydrocephalus, and I also see there is a subtle area of alter MR signal in the left temporal lobe. Similarly areas also seen in the right temporal lobe. I will want to see the. I will further proceed with the FLAIR images and T2 axial images for further evaluation of this patient.
Okay.
So on the yes, on the FLAIR images, uh, there is a mild degree of hydrocephalus is seen, and there is area of small area of altered MR signal is seen in the bilateral temporal lobes, and there is also another area of altered MR signal is seen in the posterior fossa, just spirit to the fourth ventricle, which is causing compression, mild compression on the fourth ventricle. This I need post contrast images For
Okay, what's your differential here?
here this could be finding maybe due to infective etiology with the hydrocephalus and will most likely due to meningeal enhancement. And second, there is the area which are altered signal is noted in the post cerebellar vermis. This could be infective cause, could be tuberculoma, could be could be slow growing tumor which is causing obstructive hydrocephalus. So this needs a post contrast scan before they giving any reasonable differentials. Yes, on the post contrast images here I can see there is an enhancing mass lesion is seen, which is causing the compression of the fourth ventricle, uh, and there is the dilatation of the third and lateral ventricles. So the my findings likely represent a neoplastic mass lesion. This does not seem to me neo infective region. So this appears to be neoplastic in origin. This finding should be
Is it
conveyed to.
intraaxial or extraaxial lesion?
Yes, this to me this appears to be, although this appears to be intraaxial, but I'm not. I will confirm it on the other images like coronal and sagittal images for further verdict to me further confirmation. Yes, on the sagittal images, this mass appears to be extraaxial in origin, which is causing the obstruction of the fourth ventricle, dilatation of third and lateral ventricles. So this could be represent meningioma.
Why are you not you are not scrolling the images?
Yes, I could not. I don't know. Yes, yes, no, yes, no. I'm trying to. Yes. So this mass appears to be extraaxial in origin. It reveals the homogeneous enhancement, and this is a female patient, and this is the history of lethargy. It is not associated with any large vasogenic edema. So these findings likely represent slow growing tumor, extraaxial tumor most likely represent meningioma. I will also want to see on the coronal images of this, and will compare with the previous study. This patient needs immediate this patient needs surgical neurosurgical review for possible resection of this tumor. This should be resected.
Here we go. Give
So
you the
this
history. 2 months respiratory distress.
4 month. This is the X-ray
Two,
chest.
two, 2 months.
Okay, this is the 2 month. This is X-ray chest of 2 month old child. This is a portable X-ray. Here I can see there is a homogeneous opacification is seen in the right lung. Left lung appears relatively normal. There is a pleural effusion is also seen on the right side. Uh, the right lung homogeneous opacification with the pleural effusion on the right side. Left lung is normal. Now I'm looking for any rib fracture, any bony pathology. There is no rib fracture is seen. Uh, no bony pathology is seen. No pneumothorax is seen. No lines and tubes are seen. So the opacification in the right hemithorax with pleural effusion on the right side. These findings likely represent infective etiology with this pneumonic consolidation with parapneumonic effusion. I will compare
Where is the mnemonic consolidation?
this homogeneous specific. This could be pneumonic
Where is it?
consolidation.
Can you show me?
This right mid and lower zone, because we cannot see the right heart border. Right heart border is obscured. I can this one I can show. This one,
Okay.
the right hand border is obscured, and this is
Any other
the
possibility?
blunting of the right CP angle. There is a loss of lung volume is also seen on the right side. There is a hyperinflation of the left lung. Other pathology could be this say McLeod syndrome. Uh, in the McLeod syndrome, there is a hyperplasia of the lungs, and but the against thing is that there is some pleural effusion on the right side.
Any pulmonary hypoplasia here?
There is loss of lung volume on the right side, so
Okay.
that is the
What could be the causes for low
this
lung
could be
volume on the right?
this could be McLeod syndrome. This could be some infective etiology. Mm,
What is the infective etiology will cause decreased lung volume?
there's some sort of pneumonia, which can cause the bronchopneumonia, which can cause involving the whole lung, can cause, although there is, when there is one lobe involved, there is usually expansion of the lobe, but when there is a whole lung is involved, there is some typical pneumonia which can cause loss of lung volume. And in
Okay,
addition,
what will you do next for this patient?
we will compare with the previous x-rays, and we will do follow-up x-ray after a course of antibiotic therapy. If the patient is suffering from the fever, then
No
this could,
fever,
no
no
fever,
signs of infection.
no signs of infection. Okay. Uh, this could be McLeod syndrome. Um, then we just repeat the x-ray. Mm,
Anything else? Okay, we did the CT with contrast.
okay. Oh, CT scan. Here I can see the CT scan of the same patient. This CT scan chest with contrast. Here I can see there is the mediastinal shift toward the right side, and uh, yes, I can see the lung window. I want.
Okay, give me the abnormalities in
I think there is
the
abnormality
because if
lies.
you
I think abnormality lies in the left lung. There is the
okay
hyperinflation of the left lung is noted with mediastinal shift toward the contralateral side. This likely represent congenital lobar emphysema on the left side. Um, However, I also want to see the on the lung window. And this patient, if the congenital, the findings on the lung window, uh, yes, on the lung window, the findings are not typical of congenital lobar emphysema. Rather than, I think there is a hypoplastic right lung, and with mediastinal shift toward the right side, and there is the hyperinflation of the left lung. So these findings likely congenital in origin, just like due to pulmonary hypoplasia. Not no evidence of any pulmonary congenital lobar emphysema. And there is, in addition to it, there is soft tissue masses also seen in the right chest wall. I don't know what this could be. This could be
yeah,
some.
I think it's breast
This
shadow.
bilateral. These are bilateral. So these are not any very symptom. These are bilateral.
Okay, 25 years old male patient with no available history.
So this is 25-year-old male patient with no history available. I think this is the bone scan, and here I can see mm, there is images are a little bit fuzzy. Uh, there's a contrast. There's a respiratory retractor uptake seen in the lungs, and this is the bones, ribs appear normal, the pelvic bones appear normal, the femora appears normal, the tibia and fibula also foot appears normal. There is some the area of reduced uptake is seen in the skull bone. Can I see the other images of this study?
It's the only images for the study.
Okay. So I will compare this nuclear scan with the
What is the abnormality?
um, Normality is there is a high uptake is seen in the pelvis. That is in the
The
bladder.
aorta bladder.
This bladder, and there is a high uptake is seen in the vertebrae, in the lower thoracic vertebrae, in the lower lumbar thoracic vertebrae. This could be due to metabolic causes. Could be due to some.
Anything else?
There is some also reduced activity is also seen in the skull, which I will compare it with with skull X-ray. Although
What could be the possible causes?
this could be due to uh, osteomalacia. Could be due to something like
Okay, ignore the about the skull. Nothing in the skull.
okay. So there is could be due to there is the bones appears to be in the reduced uptake is seen in the femora bilaterally. Tibia appears also thin, reduced volume, and on the posterior images there is high index suspicion of bilateral increased uptake on the posterior images. These findings
Where?
in the tibia and fibula, in the legs bilaterally, these having a tram-line appearance. These findings are
No,
highly
nothing, nothing.
the ribs are especially widened.
What about the right forearm?
Right
Can you
forearm.
see anything?
There is no activity is seen in the right forearm. No, there is a high activity is seen in the right forearm.
What is this?
Just about there is yes, there is a high activity is seen in the right forearm. This could be, and the proximal bones are not seen. So this could be some bone lesion in the right forearm. This could
What
be
is the criteria of this uptake?
this is a high uptake is noted. Crystal uptake is a highly high.
Is it homogeneous uptake?
Yes, this homogeneous. I will also see the blood pool phase and
Can you can you see the center here and the periphery?
yes,
Okay, same uptake.
yes. No, there is reduced uptake in the center and the high
Okay.
uptake on the periphery.
Do you
This
know
could be
this sign?
this is called the double density sign. Could be osteoid osteoma. Could present like this.
Okay, it is called donut sign.
Yes.
Okay.
Okay.
What are the possible causes for this uptake?
First of all,
And what,
osteoid osteoma could be the one of the cause. Could be
anything else?
Brood's abscess. Could be.
What will you do next for this patient?
We will compare with the plain X-ray, and we will inform this finding to the referring physician. And this could, if there is a bone X-ray just above. Okay, this is the same patient.
The plain radiograph of the patient.
This is the X-ray of the right wrist joint. Here you can see the well-defined lobulated bubbly appearance. Lesion is seen in the distal end of the tibia. It is extending up to the articular surface. I could not see there is this having a narrow zone of transition. There is no evidence of cortical dissection and no adjacent soft tissue mass formation is noted. Fibula this radius ulna appears normal. Rest of the joints appear normal. So these findings are suggestive of locally aggressive tumor, giant cell tumor of the patient because the patient is with fused skeleton. So these radiographic findings are suggestive of giant cell tumor. I will immediately inform this finding. I will inform this finding to the orthopedic department. This patient should be managed by the orthopedic department.
What could be the management for this patient?
This patient needs some grafting or some local bone chips. This is not malignant tumor. There is no need of any X-ray, CT scan, chest.
Okay, can GCT metastasize or not?
Very rare it can metastasize. It can metastasize, but very rarely.
Okay, thank you. How did you find yourself
I don't know. You are the judge.
How are the difficulties of cases?
Bone scan. I don't know what was that. It was very confirmed, and that there the X-ray of the chest was also very difficult. Bone child X-ray.
Okay, no problem. Okay. In a bone scan, okay, we have to see where is the abnormal uptake. First of all, this MDB, technetium MDB bone scan, you have to detect is it super scan or not super scan. We can see the kidneys here. This is the frontal view, this is the posterior view. We can see the kidneys, so it is not super scan. Okay, all the spine, everything, uptake except this area in the right forearm, and it doesn't show uniform uptake. It show increased peripheral uptake and decreased central, giving the appearance of donut sign. Donut sign at this region, and this large lesion, it is not likely to be osteodystoma. Osteodystoma is uh, a small lesion, and it is not the typical location. Differential here include aneurysmal bone cyst, giant cell tumor, simple bone cyst, or chondrosarcoma. Okay, a
Okay.
bone scan is sensitive but not specific. It can detect the pathology very well, but from bone scan only we couldn't detect what could be the pathology. Okay, so always you have to correlate with plain radiograph. Okay, here plain radiograph is very easy. Subarticular, expansile, central lytic lesion with multiple internal septations. Some cortical breach can be appreciated here along the lateral aspect. However, no such more soft tissue component, no aggressive porosity reaction, so it is likely to be uh, more to benign lesion. However, the differential here will include also giant cell tumor, aneurysmal bone cyst, or simple bone cyst. So this patient needs biopsy and further curettage and bone grafting. Okay, that biopsy proven a giant cell tumor. Okay, bone scan is very important in the exam. You may face one case at least for nuclear scan. This case, okay, 2 months. You can see the right lung is small. You can see there is tracheal shifting to the right, heart shifting to the right also. Okay, some reticulation here or opacity. Left lung slightly small, but not like the right one. So there is pulmonary hypoplasia. The possible causes for pulmonary hypoplasia, okay, may be due to any compression effect on the bronchi or outside, like diaphragmatic hernia or CPAM like this, but or sequestration, but is not, they are not present here. So maybe decreased pulmonary vascular supply, okay, like any cardiovascular anomaly, hypoplastic right heart, hypoplastic pulmonary artery, scimitar syndrome, or any vascular cause, okay. So this CT, I give you first the contrast study. Very, very important to look at pulmonary vessels, okay. You have to look at the pulmonary vessels. So here you can follow the pulmonary artery, main trunk, and right and left main pulmonary are okay. So then you should look at the pulmonary veins. Okay, what is
Okay.
this? This one.
Scimitar syndrome.
I know, but what is this? vessel.
Partial anomalous pulmonary vessel. Vein, it is vein.
Yes, this is a pulmonary vein. You should trace it. Okay, it is going to
Atrium.
inferior vena cava. Okay, so it is not uh, going to the left atrium. Okay,
Okay.
so it is partial anomalous pulmonary venous return or a scimitar syndrome with hypoplasia of the right lung. I think the operation may be diversion of the pulmonary vessel to be in the heart like this as a part of treatment. Okay.
Okay.
And also this patient may come with pulmonary hypertension and something is complication like this. Okay, this case you did it very well, but except you couldn't detect the abnormality on T1. I don't know why. Here, there is crowding of the foramen magnum. Here, there is the medulla is compressed to the left side, and you can see hydrocephalus. Okay, if you saw any hydrocephalus, you have to look at the cause. Okay, is it communicating or not communicating? So you have to trace here third ventricle, cerebral aqueduct, fourth ventricle, and then come down. We'll found iso-intense soft tissue mass here. It's compressing also the left vertebral artery and basilar artery also to the left side. So you can ask for T2. T2 showing there is some CSF permeation, which is an emergency for shunting, and then also demonstrate the lesion to delineate well as you are told. We should ask for the contrast study to homogeneous contrast enhancement. Appears to be extra-axial because it is compressing the vessels, and here compressing the medulla posterior, so significant mass effect likely to be and homogeneous enhancement on post contrast and not hyper intense on T2. Differential here will include foramen magnum meningioma. It is not a bony lesion to suggest any chordoma or chondrosarcoma or something like this. It is extraaxial meningioma in the foramen magnum. Okay, unfortunately, this image stack not working. However, this is upper loop fibrosis. Okay,
Yes.
so you have a wide differential for upper loop fibrosis. Sarcoid can cause this feature. Also, ankylosing spondylitis, also cystic fibrosis, but less likely in this case. Okay, tuberculosis also and pneumoconiosis like silicosis can cause or progressive massive fibrosis. There is here, but it was in the mediastinal window, but it is syndesmophytes and uh, fused costovertebral junction. Okay, it is suggesting the diagnosis of ankylosing spondylitis with bilateral upper loop fibrosis. So you have to refer the patient to pulmonology and rheumatology MDT for further assessment, and also you can ask for HLB27, BA27 assessment. Here, I don't know why you know how to tackle the cases of ultrasound. It's very easy to go through them. Okay, I give you first this one. So here, the left testicle, you can see the volume. It is seen of average size. You can present like this. Here I can see the left testicle. It is well defined of average size and homogeneous echo pattern. Okay, I can see a part of the right testis, but I couldn't assess well. However, while I'm going through up, I can see some heterogeneity of the right testicle with some areas of focal hypointensity. I'm concerning about differential of infection, as you told, or if any history of trauma, maybe testicular rupture. I can see here also the epididymis seen heterogeneous, and I'm looking for any tunical disruption. You can see here the tunica is not intact. Tunica is a white line goes through around surrounding the testis. Okay, and you can see here also hematoma, and here no tunica we can see. Okay, this region. So it is a case of, and also you can see the volume is double volume of the right testis compared to the left one. So it is a case of testicular rupture. Most important sign in testicular rupture is tunical disruption. Okay. The management, as you told, will depend on if the testis is salvageable. Okay, they can suturing the tunica and preserve the testis. If it is necrotic and heterogeneous and not appearing well during the operation, so they can do orchectomy. Okay. Okay. In this case, simple case for cranial ultrasound, you can see hyperechoic content seen extending from the caudosalamic groove to the frontal horn, both lateral ventricles. However, no any associated ventricular dilatation. The rest of the parenchyma appears normal with no any cystic changes, and also the cerebellum is present. In my routine practice, I'll have to look at the other orthogonal planes like sagittal planes. Sagittal planes confirm the presence of germinal matrix hemorrhage anterior to the caudosalamic groove. This is the choroid plexus. So the diagnosis of this case is germinal matrix hemorrhage grade 2. I will inform the referring neonatal team and keep the patient under conservative management and follow up after 24 hours. No need to ask for CT scan in neonate, okay? Except in surgical cases, okay? Safety point, Dr. Mujahid, okay?
Okay, thanks a lot, thanks a lot, thanks a lot.
And I need from you to, I don't know the problem in your mic or your sound or your voice is like this, but try to raise your voice, talk clearly, okay? Present yourself in front of the examiner. It is very important in the exam, okay?
Okay,
Thank you so much.
thanks a lot, thanks.
Please, in GCT donut sign, can we put eosinophilic granuloma and differential? Really, but it is the case. I think the age is against eosinophilic granuloma is older age group. Where is GCT referred to? GCT referred to orthopedic. It is locally aggressive tumor, not malignant tumor. So orthopedic can do curettage and can do
Yes.
uh, grafting for the patient. Okay. Okay, Dr. Sameh, are you ready?
Yes, sure.
Okay, boss. I will give you the history for this patient. Consider it adult female patient come for screening.
Yes, shall I request the control?
No problem. No
Many.
scrollable
Okay.
image, but you can ask no.
So I'm presented by bilateral mediolateral oblique views of mammography of elderly patient. came for screening. I can see in the right breast shadow there is well-defined opacity seen at the retroareolar region. Also in the upper part of the left breast, there is smaller area of opacity seen. Yes, here the right breast looks normal, no evidence of
Okay, so
uh,
in the start you described the left, yes?
yes, yes, I described the left
Because you
side.
told the right
Oh,
retro earlier.
yes.
So you yeah, concentrate in this.
Okay.
Okay.
Also, I'd like to assess the ACR of the breast density. It is likely ACR2. Uh, and this tool opacity seen in the mediolateral oblique views. I'd like to compare in the craniocaudal views of this the left breast. Here, the pertinent negatives, no evidence of nipple retraction, no evidence of skin thickening, no evidence of axillary enlarged lymph nodes. In the craniocaudal view, I can see the retroareolar lesion is seen well-defined lobulated, with no evidence of speculations, no evidence of microcalcifications. However, I will use the magnification views and zoom tools to confirm this. The other lesion seen at the deeper area looks ill-defined in this image, and there is minimal speculation of this lesion. It is for me suspicious for subtle malignant lesion. I will request compression view of this lesion to confirm.
Which one? This one? This
Y-
lesion?
Yes, yes, this one. I think in the other, yes, this lesion, yes, compared to the other side, it is. Uh, there's increased density with irregular outlines. If there is a compression, I will request compression view for this lesion to check it clearly, as I'm suspecting this lesion to be subtle or early malignant lesion. If this
Okay.
patient
What is the grade of this lesion in mammography, and what will you do next for this patient?
Yes, in mammography, it is of M3 lesion because it is no typical criteria for malignancy, but it's
Okay.
still
What will you do
suspicious.
next for this
So I
patient?
will recall the patient for triple assessment by clinical examination and the ultrasound assessment of this lesion. If it is appear clearly in the ultrasound and accessible for biopsy, it will be
What are the differential for this lesion?
differentials for it is early malignant lesion. The other differentials is radial scar if this patient have any previous operations. Uh, this will be assessed in the triple assessment of the patient. Clinical ultrasound and biopsy if accessible by ultrasound, and if not accessible, uh,
Okay. Here is the
yes, here
ultrasound of the patient.
ultrasound of the same patient, I can see this is likely the retroareolar large lesion, which is seen lobulated of well-defined outlines and cystic appearance in the ultrasound, which is of benign features, M and U, 2, grade 2. I'd like to scroll through the images to see the other suspicious lesion in the
You can
image. I
scroll.
don't know. This is scrollable.
Yes,
Okay.
yes.
Yeah. And trying to scroll. Yes, this is a smaller lesion uh, of the same patient. Here in the ultrasound, it is seen parallel to the skin with fusiform oval shaped, well-defined outlines, no evidence of speculations, no evidence of microcalcifications. Also, I'd like to use the Doppler study for this to assess if there is vascularity inside or
What's
not.
your final diagnosis, management?
And so this is likely also it is a benign looking lesion and the other one cystic lesion. Both are of MU2 grading. So this patient will go back to the regular screening program for here, no evidence of suspicion.
50 years old male patient with abdominal discomfort.
Yes, so I am presented by axial CT scan of 50 years old female patient of abdominal discomfort. I'd like to scroll through the images before commenting to take a look. I'm scrolling through the upper abdomen, checking the upper abdominal organs, and here in the lower abdomen. Yes, reaching to the, I think the last images of the lower abdominal region. Yes, so from the first look, I could detect evidence of fat stranding seen around the sigmoid colon, and also there is some air, yes, air foci seen at this area, and there is engorgement of the mesenteric vessels at this region. Uh, I am searching for yes, diverticuli, as I'm suspecting diverticulosis, sigmoid
Anything else
diverticulitis.
other
Uh,
than this diverticularly?
yes, I'm still searching for yes. There is yes, fat stranding at this region, and also I can see there is small bowel area showing sorry, there is lag in the scrolling. I will go back to this area as also I could detect there is evidence of cecal dilatation, and also the right iliac fossa there is uh, mild dilatation of the cecum. Here I'd like to
Okay, ignore
assess.
about the bowel, please.
Yeah,
Go up. Anything else?
so I am going up to the upper abdominal area here. The kidneys looks normal. The liver also is normal, and the spleen, the tail of the pancreas, I can see there is bulky appearance. Uh, I will go back to this area as there is focal bulge at this region with a lot of the normal fetary appearance of the pancreas. It is worrying for any focal lesion, isodense in in this study. Uh, yes, here at this area.
Okay, what are the possible causes for this appearance?
Yes,
And and what
so
will you do next for this patient?
this appearance could be focal neoplastic lesion like IBMN, intraductal
Is it solid
papillary muscle
lesion?
neoplasm. It is ISO here, but not enhancing. So also the possibility of a small cystic lesion could be in the differentials, like mucinous cystic neoplasm. I will use the pancreatic protocol for triphasic study for assessment of the differential.
Okay, we did MRI for this patient. You can scroll.
Yes, I'm scrolling through the MRI study of the same patient. I will go to the area of concern directly. It is BVT2 uh, fat set images. Here, this area is seen hyper intense in
Okay,
T2
this is a T1.
weighted M. Yes,
This is a T1. Okay,
yes, this is a T1 image of the same patient showing low signal in the center of the lesion.
okay. This is a
I
post
think this is
contrast.
post contrast. It
I'll
is,
show you the sequences. Okay,
yeah,
on the
yeah, yeah.
same region, and then see and give me the arterial phase.
Yes,
This is
this is
the portovenous
Portovenous
phase.
phase.
Okay, I'll go up. Okay, and this is the uh, delayed phase. Okay,
Yes.
and this
So,
is the diffusion.
yeah.
Okay,
Uh, So
what's your final
this
diagnosis?
lesion is showing characteristic appearance of cystic lesion in the different different images of the MRI study. The possibilities here is mucinous cystadenoma as a first because it is well defined and likely solitary lesion unilocular, no evidence of large septations. And I didn't detect any calcification in the CT scan. No evidence of duct dilatation
Okay,
as well.
what is the final
So,
diagnosis and
so
management?
this is mucinous cystadenoma of the pancreas. This patient needs to be referred to the hepatobiliary and pancreatic entity meeting for discussion of the management of plan of this patient. Um, I think this patient could be go for follow conservative
Okay,
management and follow-up.
okay, 7 years old female patient with left forearm swelling and elevated inflammatory markers.
Yes, so I am presented by frontal radiograph of the left forearm of 7 years old child with elevated inflammatory markers. Through the bones presented, I couldn't detect any evidence of fractures. First, also, I can see there is mild soft tissue swelling around the proximal radius and ulnar region, especially around the proximal radius with evidence of periosteal reaction. And also, there is ill definition of the cortex at this region. I'm suspecting this patient with a correlation with laboratory data and the clinical manifestations, elevated inflammatory markers to be acute osteomyelitis. I would correlate, I will alert the referring physician about the findings, and also uh, ask for MRI study of this patient. The differentials for it could be Ewing sarcoma and also Langerhans histiocytosis. Uh, Here, the MRI study of the same patient. I am scrolling through the images. Yes, here I can see the proximal shaft of the radius showing abnormal signal in the proton density scan with prominent periosteal reaction and mild edema in the surrounding soft tissues and muscles. No evidence of cortical breach in this view. You will confirm in the axial images as well this finding, and no
Okay,
evidence
here is
of
the axial stair image.
yeah, axial stir image showing significant abnormal signal seen intramedullary in the previously mentioned region. Uh, Here I'm still scrolling through the images, the patient, scrolling up through it, detecting any abnormal cortical breach at this region. Still, I am seeing significant preosteal reaction. There is thinning of the cortex at this area, and also ill definition of the cortex at this region. Uh, there is extension of the
Here
lesion
is
to the surroundings.
here is a post contrast.
Yes. Scrolling through the post-contrast imaging to see the contrast enhancement of the lesion and the extension to the surrounding structures. Uh, yes, here I can see the high signal enhancement, uh, significant enhancement in the previously mentioned region with evidence of smooth
Okay, what are the
surrounding
possible
perostal
causes
action,
here?
and also soft tissue edema around it. The first top differential for this case is acute osteomyelitis. I
Okay.
will refer the patient for orthopedic
Okay,
team
before
for the management
referring,
of the
we
patient.
did MRI on both legs due to the patient complaining of bilateral leg pain.
Yes. Uh, I am scrolling through the links for assessment of the bones. As yes, here I can see there is bilateral affection of the tibia at both sides with rather similar findings to that of the radius. And the soft tissue affection also has rather similar appearance. All these findings with the elevated inflammatory markers of the patient raise the possibility of Kermo, chronic recurrent multifocal osteomyelitis. I will alert the referring physician urgently about this finding and refer it to the orthopedic team for management,
Okay,
the
30
antibiotic
years,
therapy and follow-up.
okay, just non-steroidal anti-inflammatory. Okay,
Yes.
30 years old male patient uh, with acute abdominal pain.
Okay. I'm now presented by 30 years old female patient with acute abdominal pain. This axial non-contrast study of the abdomen. I'm scrolling through the upper abdomen, checking now the liver, spleen, and uh, yes, the kidneys. Like to take a general look first before commenting on the scan. Uh, from the first look, I detect there is abnormal area of fat stranding seen at the upper abdominal region around the pancreas and the stomach. Uh, there is also mild dilatation of the bowel loop. So I will go back to the upper abdomen for assessment of this suspected abnormality first, then go through the whole images for assessment. I can see here in the presented image, there is nodular, abnormal nodular thickening of the momentum at this region. Also, the wall of the stomach is showing irregular wall thickening at the region of the pyloric region, and also there's extension of the process as large soft tissue seen infiltrating this area of the stomach. I couldn't detect here clearly the gastric wall, really, and at this area there is serrated appearance of the thickening of the gastric
Okay,
wall.
what is the main abnormality here?
So the main abnormality here is diffuse gastric wall thickening with ill definition, and also there is nodularity in the momentum around
What's your
it.
opinion
I'm
about the bowel?
suspecting, and the bowel also there is bowel dilatation. Uh, there is area of bowel dilatation I detect from the first look.
Okay.
Uh, Here, the dilated bowel loops with finding of the gastric wall thickening and no evidence of hernial orifices. Hernial orifices here are clear, no evidence of herniated bowel loops to cause this dilatation, and also the possibilities for this finding in the
Okay, look
stomach.
at the post contrast.
Yes. Post-contrast study of the same patient. I am trying to trace through. Yes. Yes, here in the post-contrast study, I am checking this area in the stomach first to confirm, as the stomach here is seen dilated
Ignore about
with,
the stomach, nothing.
yes, yes. Uh, and also the pancreas.
Where is the left kidney?
Yes, left kidney, yes, it is not seen here in this image, so it is likely surgically removed. Uh, Also, there is hepatosplenomegaly seen, and the bowel loops are seen hyper-enhancing wall with mild ascites seen at the right iliac region. There is also here small bowel feces sign.
Okay.
So I'm searching for possible area of intestinal obstruction at this region. And yes, here, and I can see also there is pneumatosis in the wall of small bowel at this area, which is uh, I-
Pneumatosis, not be seen on the
Yes,
anterior wall.
in the posterior wall, I couldn't detect it clearly. Also,
So
there
don't
is,
don't tell pneumatosis except you can see
yes.
in the lower wall. Okay,
Here I can see there is the obturator foramen at the right side. Uh,
okay. Here there is intestinal obstruction. Yes or no?
yes, yes, there is intestinal obstruction. Yes.
What is the cause?
Uh, Here there is the small bowel feces sign is the targeted area for transition zone.
Okay.
I am searching for the cause at this area. Uh, yes,
What
going
are the
down
possible
to
causes in this patient?
the possible causes of this patient adhesions, and also could be if there is a metastatic lesion
Okay.
of
Any
this left
complication?
nephrectomy. No, there is ascites, mild to moderate amount of fluid collection in the abdomen. No evidence of pneumatosis or portal venous gas at this region. So I will review the medical record of this patient to see the cause of left-sided nephrectomy. If it
Management?
is with malignant lesion, I will refer the patient again to the oncology MDT meeting for restaging, and also urgently before this, I will urgently refer the patient to the surgical team for management of the intestinal obstruction surgically, and after that, referred back to the oncology MDT meeting for discussion of the management and the restaging.
60 years old male patient with chronic chest pain.
Yes. So I am scrolling through axial CT scan with contrast for 60 years old female patient with chronic chest pain.
Male patient.
Male patient, yes, with chronic chest pain. Yes, I would like to scroll through the whole images. Yes, I think this is the last image of the study. It has the other abdominal cuts. I looked through it. Going back to the area of the heart, as I can see, there is evidence of moderate amount of pericardial effusion, and also there is gas lucency seen at the posterior aspect of the pericardial space. Uh, the enhancement of the aorta and main vessels here at this region. I can see there is large soft tissue or mass lesion seen at the subcarinal area, and also it is yes, compressing the uh, main bronchi bilaterally. It is of hypodense appearance, well-defined outlines. However, yes, and there is enhancement through this uh, soft tissue area, and there is focal bulge arising from the thoracic aortic arch, and this surrounding large soft tissue area, likely representing large intramural hematoma with this pseudo aneurysm of the aortic arch. It is an emergency. This patient needs to be urgently referred to the cardiothoracic team. And I'd like to assess the pre-contrast study of this patient to confirm this soft tissue area to be hyperdense in the pre-contrast study, and refer the patient urgently to the cardiothoracic team for surgical management, as it is uh, complicated Stanford acute aortic injury with pseudoaneurysm and intramural
Where is the site
hematoma
of
as
injury?
here in the pre
Is
in
it
the
acute aortic
aortic.
syndrome? Our pseudoaneurysm is one of the causes of acute aortic syndrome.
No, if it is penetrating ulcer and ruptured with uh,
Okay, ignore
yes,
about the
aneurysm for
classification now.
yeah.
Okay, anything else?
There is pleural effusion and pericardial effusion, large amount of pericardial effusion. There is also vascular uh, linear hyperdense structure. Likely, this is vessel as this lesion. I will ask about the history of this patient if he has recent history of cabbage uh, operation. Could be this is
No
internal
history of
mammary,
operation.
no history of operation. Yeah, yes. So this is a case of acute aortic syndrome, and this patient needs to be urgently referred to the cardiothoracic team for management. As also here, there is signs of cardiac tamponade due to the large amount of pericardial effusion and the pericardial thickening.
Okay. This patient, 50 years old female patient, presented with ataxia.
Yes. I'm presented by MRI study, uh, axial flare image of patient complaining from ataxia. Here, I think this is the last image of the study. Going back through the posterior fossa. Yes, here is the posterior fossa. Looks normal, no evidence of large posterior fossa mass lesions. Yes. At the upper yes, at the fault of the subcortical areas of the right of the left occipital region, there is abnormal high signal areas bilaterally and also at the right side, scattered in the subcortical region and white matter as well. Uh, Also seen in the frontal region and the corpus callosum. Uh, the posterior fossa looks normal, no evidence of abnormalities here. So this abnormal signal at this area is worrying about any possibilities of toxic disease or vascular abnormalities. Here at the periventricular region, it is clear at this area. I will ask about any history of hypertension in this patient or
No hypertension, just ataxia.
yes. So in case of ataxia, I'd like to assess the posterior fossa and the vascular structures at the base of the skull, uh, as I could, I'm searching
Okay, what
for
will you do
any.
next for this patient?
I will recommend checking the SWI and uh, contrast enhanced images of this patient.
Okay, here is the post contrast.
Yes, the post contrast image of the same patient. Yes, scrolling through the images, I can see there is multiple parafalcine high signal foci at the central gray matter region. Well, this area is seen hyper enhancing at no evidence of other abnormalities.
What about the cerebellum?
Uh, cerebellum. I didn't detect any abnormality in the first look in the cerebellum, but here I can see there is multiple hyper intense areas. The right cerebellar hemisphere.
Okay,
Also, there is, I think there is abnormal vascular structure seen in this region.
okay, here is the surgical post contrast. Look at this sequence and give me your diagnosis.
Yes. So this is sagittal T1 weighted image of the same patient. Yes, there is evidence of abnormal high signal seen in the cerebellum at this region, and also there is prominent extraaxial CSF species with, I think there is also sagging of the corpus callosum and the brainstem at this area, uh, and flattening of the vermis of the cerebellum. Also, the meninges showing hyper enhancement of the back meninges. I'm suspecting this patient to be hypotensive uh,
This
hypotensive.
plain radiograph of the chest 3 months ago.
Uh, Billion radiograph of the same patient 3 months ago. Uh, so this is the frontal sheath radiograph of the same patient. There is mild cardiomegaly, uh, and there is prominent hilar shadows bilaterally. Uh, Likely this enlarged lymph nodes. Mild reticulations, very hilar, are noted as well. No evidence of lung lesions, no evidence of destructive bony lesions, no evidence of pneumothorax. So the possibility of this appearance could be a case of sarcoidosis with lung and brain affection. I will review the medical record of the patient and also uh, assess the ACE level and the calcium level of the patient to confirm the diagnosis.
Okay, thank you. تمام.
Welcome.
يا بص here okay flare okay abnormal signal seen here subcortical white matter bilateral and along the pyramid line of the frontal lobes this on the periaqueductal okay non-specific finding so we ask for post contrast. Here the post contrast okay the same areas show a contrast enhancement and here the area of periaqueductal on the right side likely also show also perithalamic also show a contrast enhancement and on the right cerebellar hemisphere okay sagittal you can see here the area of hypothalamus some enhancement tectal plate and all this enhancement what is the pattern of this enhancement?
Uh, this is leptomeningeal in the basal system.
Yes but nodular
Mm.
nodular leptomeningeal enhancement okay
Yes.
so the differential here will be
TB and
sarcoidosis,
sarcoidosis.
tuberculosis. Okay, maybe less likely to be metastases. Also, there is some thickening, subtle thickening in the dura. Here is the involutionary changes involving the whole brain. Okay, no such so much subdural collection or like this. So, a differential neurosarcoid or tuberculosis. Simply, you can ask for plain chest radiograph. Also, this is the area of hypothalamus. Okay. Uh, hypothalamic involvement may be also LCH and IgG4 hypophysitis like this. Chest radiograph, left hilum and left paratracheal lymphadenopathy. If I showed you the CT scan, extensive lymphadenopathy in the chest and some parenchymal changes. So it was a case of systemic sarcoidosis with involvement of the brain, neurosarcoid. Here, okay, two pathologies. There is one pseudoaneurysm from the arch of the aorta with large mural thrombus, okay, which is an surgical emergency. Another pathology here, there is air foci seen in the pericardium and there is pericardial effusion. Okay, you should search for the cause of this air. Maybe infective, maybe anything else. Okay, so you can go here in the stomach. Okay, so you can see the connection between the stomach and the pericardium. So it is gastropericardial fistula. It is an emergency also with uh, pericardial effusion and pneumopericardium. Okay, there is multiple fun pleural effusion, lung collapse, and all things like this. Okay, so try to search for the cause of anything you can see. If you found the cause, it will be very well, or you have to suggest the cause. Cause may be here, may be infective, maybe fistula formation, iatrogenic, according to the history of the patient. And here in the coronal image, you can see the connection between the stomach and the uh, pericardium. Here, a simple case, this stomach is okay. This fusion We couldn't see the left kidney and left adrenal, okay? And there is surgical clips on the left side, okay? So likely related to previous operation, okay? And then you can go to the bowel. Bowel is seen dilated, multiple air fluid level. So this case of previous operation and now intestinal obstruction. First of all, you have to look at the transitional point. As you told, there is fecalization here of the distal bowel, and this is the fecalization. And here is the transitional point. No hernial orifices, no any other cause. So it may be likely to be adhesive. However, in your routine, you should ask for if you presented with non-contrast, you should ask for the contrast. And then you have to look at the orthogonal planes. Okay, here is the coronal. You can see here around the transitional point. Okay, there is collapsed bowel loop and there is some twisting here. So it is likely to be adhesive
Yes.
intestinal obstruction or internal hernia, whatever the cause, but it is a surgical emergency. You have to call the surgeon and go for operative management. Okay. No need here to refer to oncology. Okay. Nothing related to. Okay, maybe the patient has previous neoplastic process, but now we couldn't see anything except this intestinal obstruction related to adhesion. Well done in this case. Okay. Okay, this preostal reaction, some soft tissue swelling, okay, Ewing, Langerhans, osteomyelitis, all these are our differential. MRI also, but here we can exclude Ewing, okay, because of, and also there is not so much bone involvement, just edema, okay, so we can exclude neoplastic. We can put here osteomyelitis as our first differential. However, no any collection, no Brody's abscess, no nothing like this. Here is the post contrast, no so much soft tissue components surrounding the bone, suggesting Ewing sarcoma. So we are going for osteomyelitis. Okay. Then we showed you the other areas of involvement of the bones. So it is chronic reactive multifocal osteomyelitis. We can refer this patient to rheumatology team and the patient need non-steroidal anti-inflammatory. Actually, it is a diagnosis of exclusion, okay?
Yes.
And multiplicity sometimes like this. And they may show it may show so much bone expansion and then sclerosis at the late stage. Oh, this patient of pancreas. Okay. Here is the always if you presented with abdominal CT, try to go through the organs one by one first and quickly. Look at the liver, look at the suprarenals, and look at the pancreas, very important, and look at the spleen and the kidneys. Pancreas is very important because the whole pancreatic pathology are subtle pathology. If you saw our lecture in afternoon, there is subtle, small hyper enhancing lesion here. So pancreas, you have to concentrate very well on the pancreas because all of the pancreatic pathology, pancreatic carcinoma, pancreatic neuroendocrine tumor, uh, subtle autoimmune pancreatitis can be also subtle pathology. So in the pancreas, try to concentrate more. Here you can see the pancreatic tail is prominent and there is loss of convolutional appearance of the normal pancreas. However, we couldn't appreciate any mass lesion in the underlying pancreatic parenchyma. So likely to be inflammatory other than neoplastic, Dr. Sam. Okay.
So
So
far, that's trending.
Yes, yes. Sometimes no, so much fat sign. This real, really, it is a case of focal autoimmune pancreatitis, IgG4 related. So no, so much strength, just bulky pancreas. On the contrast or in the MRI, it appears to be hyperintense. Okay, but the pancreas itself is hypointense. Okay, and it showing contrast enhancement on the delayed phase. Okay, and I think no cystic changes here to suggest any cystic pancreatic neoplasm. So you have to put the possibility of inflammatory process through the pancreas, and you can ask for IgG4 level and look for other associated IgG4 related disease, or you can tell it is a case of autoimmune pancreatitis. This case of the breast case is a gift in the exam. Simple case, and you can, but don't go more deep in a finding you couldn't see well. Okay, this well-defined macrolobulated retroareolar soft tissue density, no any skin retraction, no any skin thickening, no any internal calcifications, no any parenchymal or architecture distortion. So it is likely to be a benign lesion. We can give it in initial scoring M3. Okay. There is another smaller lesion. If you can make zooming, you can see it is well defined also. Okay. No any associated calcification, no any speculation, or you can see the vessels go through it and no any parenchymal distortion. So it's likely to be also a benign lesion, but this patient is came for a screening. Okay, we can give it M3 first and ask for the patient to come for triple assessment. Okay, this patient should be clinically assessed and go for ultrasound, and then this patient may need biopsy. Okay, this is a tomosynthesis of the patient. No so much data given by tomosynthesis, no calcification, no architecture distortion. And then we go for ultrasound, confirm. Okay, the differential here also could be include fibroadenoma cyst, and this also maybe fibroadenoma, maybe cyst. Okay, so it is likely to be more to be benign. Ultrasound confirms the presence of this well-defined clear cystic lesion with back enhancement. Okay, and there is macro loculation, but always it is benign. Here the localizer. Okay, you can see the localizer here, or they can tell you written which quadrant, which look like this, and then scroll through the image, the same lesion, and this is the other lesion. As you told, this is a well-defined, smooth margin, slightly echogenic lesion seen with it is wider than taller and not and going with the breast parenchyma in the left upper quadrant. Okay, and here also it can show there is some back enhancement likely to be fibroadenoma, and this case may need follow-up. If you are in the exam, you can ask for 6 months follow-up for this lesion. However, it is likely to be benign lesion. Okay. By the way, this patient did fine needle aspiration biopsy, and it is confirmed to be fibroadenoma. Okay, so not all the cases in the exam will come malignant. Okay, they may present you with benign lesions. Okay, I think one, three, four, five, six. Okay, we finished the cases for today. But Dr. Sameh, you need to raise your tempo. Okay,
Yeah.
you have to go and target in the exam. Okay, The examiner need from you 1, 2, 3, 4 to finish, no time. Okay? So be in target in the case. Okay. No, any question? Any question for the cases today? Okay. See you tomorrow, inshallah, at the same time. Just
Thank you.